So let's move on a little bit now to kind of estrogen receptor resistance, and I think this is something that Carlos has been involved in for many, many years. Do you have any comments about kind of what's known to date, at least of the basic biology of hormone resistance?
Sure. I think that we've learned quite a bit over the last few years. The only really validated mechanism of resistance is HER2 gene amplification. We know that, and we know how to treat those cancers now with combined therapy. We also know that tumors that I don't believe that tumors change lineage. They always remain ER positive. So I tend not to believe on the loss of ER unless the tumor has 1% ER to begin with.
Okay.
But I do believe that tumors, we know that, again, from a number of clinical observations and laboratory studies, that breast cancer cells that are ER positive lose ligand dependence and now reactivate at ER by a number of mechanisms that could be gene amplification or estrogen receptor mutations. There were four papers last year, all from good places, showing that you can detect in tumors that have progressed after AIs or tamoxifen, you can find as much as 20% of them will have an activating mutation in the ligand binding domain of the ER. And that's very important because those lesions, those alterations may be sensitive to ER downregulators by fulvestrant or by whatever better than regulators we develop later. Other ways by which this ER becomes reactivated is by the acquisition of oncogenes by the cells, by PIK3CA mutations, FGFR amplification that either signal in a bypass tract or they use the ER. They use the ER for transcription. So I think that the story here is incomplete, and I think that I see a time where we would routinely biopsy all recurrences that are ER positive and sequence their tumor genomes, and we are going to find patterns. What are the most frequent patterns that cells use? Mm-hmm. So right now we have some hints, but I think this field is going to evolve as we learn how to use these molecular tools better.
Yeah, well, let's talk about that a little bit, just about PI3 kinase inhibitors before we go to mTOR inhibitors. We know that when we sequence tumors, a large proportion of them have PI3 kinase mutations.
Very large.
Yet when we have these PI3 kinase inhibitors, there haven't been really any that have worked that well, as far as I know. I mean, would you agree that we've had benefits of PI3 kinase inhibitors?
A lot of people had predicted that, particularly those with PI3 kinase mutations might respond, and the story isn't fully out yet, but certainly the first data we've seen with PI3 kinase, even some of the selective ones, is that in the metastatic setting, the Fergie trial, for example, didn't show a signal. The story is not out yet. I think we still have to keep looking.
I'm much more optimistic than you guys.
Good. That's why I wanted to answer this for that very question.
And I think I would stay tuned to trials like BEL-2.
Okay.
Okay. I think one problem I have with the Fergie trial, and we're speaking here among friends, is that I'm not sure that inhibitor is a really good one. And these targeted therapies should inhibit the target well if you're going to see a clinical effect. Interestingly, in that study, there was a very low rate of hyperglycemia, which to me is a red flag that maybe the target was not being inhibited. I mean, unfortunately, some of these drugs, we're going to have to see some on-target toxicity in order to be able to interpret these studies. So I'm not sure Fergie was entirely interpretable.
So do you think that the class selective or alpha-specific inhibitors, even though they probably have less toxicities, may not actually be efficient enough to
No, I think the alpha-specific may do, and all the alpha-specifics out there, believe it or not, there's some alpha-specifics that are better than other alpha-specifics. So I think that you're going to see some interesting effect. The other thing is that, going back to the fact that we haven't seen a lot of activity, if you look at the single-agent study, phase 1 of BYL719 of Novartis, if you look at the RECIST response, it's identical or better than that to Herceptin as a single agent.
Really?
So, yes, absolutely.
Really?
Herceptin as a single agent is
like 16%, 15%.
It doesn't do a whole lot.
20%.
Doesn't do a whole lot. So I think that in ER positive tumors, I mean, it's a mistake. Those drugs have to be combined with anti-ER drugs. If you inhibit PI3 kinase, cells make more ER. That's well shown actually in rebiopsies. So I think you have to do combinations. So I think I'm more optimistic.
That's a good thing to hear.
I think the alpha specifics I think are going to be very, very good, and in combination with the right hormonal agent, which in my opinion should be an ER downregulator.
So go ahead.
I think
Denise,
that the other thing, because we participated in Fergie, in what we see in some of these trials is a lot of the analyses were done on the primary tumor and not on the metastatic setting.
Right,
and so I think it's increasingly important that the paradigm has shifted, and I certainly tell our radiologists and pathologists, I'm not questioning a patient's disease is metastatic, but I'm getting the tissue now to analyze the disease that I'm trying to treat, so not going back to the primary. So we do the foundation medicine, which also does report the ESR1 mutations too. So seeing some of that come back on reports too. So I think we're in that learning phase of now trying to move forward with the molecular diagnostics.
And let's kind of just end this. Go ahead, Joyce.
Yeah, if I may, because we've talked a lot about anti-estrogen therapies, combinations, potential ideas for resistance, and I think one way to complete this is to know that essentially all patients with hormone receptor positive breast cancer eventually end up receiving chemotherapy.
Yes.
So, at this meeting, we're presenting for the first time, the randomized phase 3 data of the Beacon study. And in that study, 2/3 of the patients actually had hormone receptor positive breast cancer.
Really?
And in this study, this was a very large global trial of about 850 patients randomized to this novel topo-1 inhibitor, irinotecan pegol, versus the chemotherapy of physician's choice. And in that particular trial, although the p-value for the overall study was a p-value of 0.08, there was actually a statistical significant improvement of survival for those patients with hormone receptor positive breast cancer who received the irinotecan pegol versus other chemotherapy. In addition to the benefits seen in the subgroups of patients who had a history of brain metastasis or liver metastasis. So it's another aspect of the management of these patients with refractory hormone receptor positive disease that we need to still try to look what is the best potential chemotherapy to use or to recommend for consideration.
No, I agree, and that kind of segues into kind of another topic, about mTOR inhibition. I mean, I think that we now have data, we know about Bolero-2, but we actually have some more recent data, Debu, about real-world experience, with exemestane and everolimus. Can you comment on that at all?
Well, there's a large registry study published by the German group, the Bravo study, that looked at patients that were with refractory hormone receptor positive cancers, looked at patients that received everolimus with hormonal therapy. And interestingly, it was used in multiple lines of therapy, not just second line, but a few in first, a few in third and fourth line. And they did see similar toxicities that were reported in the trials. Mucositis was probably the most important toxicity in terms of discontinuation of therapy. What we can't learn from the registry, at least yet, maybe these data will be coming out, is how these patients were managed. Because I think that as we get more astute about how to manage these drugs, capecitabine being a prime example as to how we can now use it probably more effectively than it was in the clinical trials. And I think the same is true of everolimus. I see a lot of second opinion patients where I think it was discontinued too soon. Patients maybe weren't monitored as carefully for mucositis. You actually, if you hold therapy for early mucositis or try to prevent it altogether, and there's trials looking, for example, at steroid mouthwashes and things like that, and then restart it actually without a dose reduction because you were able to stop it soon enough before the mucositis got that bad, I find that many more patients can actually take the drug for longer. So it's really a matter of knowing how to manage the toxicities and monitor them. Maybe this will come out through that experience, but I think it is important for us to look at real-life experience through registry studies because it will give us additional information, and it may contradict in some cases what we see in the clinical trials.
Yeah, I mean, there is some kind of emerging data looking at kind of what you do for these multiple later lines of therapy of using, everolimus-containing therapy versus chemo. There was actually some data that was presented. Denise, do you know anything about that data?
I think looking at the multiple lines, there always seems to be a signal, and I think it makes sense because those resistance pathways are very activated with multiple endocrine exposures, and so the signal is not quite as strong, but it certainly mimics the data that we've seen for Bolero-2.
Okay, fair enough. So.